Thank you very much. The only other comment I would have in relation to that is having worked with a lot of families and kids growing up where I had real concerns about that separation thing and jobs is to get kids used to doing work early. And many kids who struggle academically actually do fine with jobs, but they don't know that until they actually get a job. And helping them on that platform to get a job, my experience has been that's what's ultimately going to predict good outcome for these kids is being able to have a job and hold a job. But introducing that early, if you have a kid that you're worried about, really helps. Sort of a pseudo internship, but in high school or middle school to get them used to that really is sort of preventive medicine when it comes to what ultimately is difficulties launching that way. So one of the biggest issues we worry about is substance use disorders. And without further ado, we have Amy Ewell, who's the medical director of our Addiction Recovery Management Service, our young person addiction service. And in your notebook, in the bibliography, it has instructor. You got to scratch that out because she was just last week promoted to assistant professor. So, Amy Ewell.
So I'm excited to be here today to talk to you about substance use disorders and think about who's at risk and how do we help them make a change. I am going to log in real quick so I can see my slides in front of me if I want to cheat. I can just take a sec. It'll come up, but we'll get starting. But neither my spouse or I have any relevant financial disclosures to disclose. All right, we'll forget that. I'll glance.
It works. Yeah.
It'll work. So I think I want to start off with kind of talking about that substance use patterns are really on a continuum, and it makes it really hard sometimes to tell when someone's in this in-between place of either limited use, regular use, or problematic use. You know, where does someone fall? It's sometimes a little bit clearer when there's no use at all, or someone has a use disorder. And the tricky part also is when you talk to adolescents, they will all say that they use socially. And so that really could mean socially, like they used once at, a party with friends over the past year. Or that could mean socially they use before school and after school. They smoke marijuana with their friends. And they're being honest in saying that they're using socially. But all of their friends also have a use disorder. And so it's still concerning their social use because they're, using before and after school. But it's sometimes hard to kind of tease that apart. And I think can be definitely hard for parents and concerned adults about kids. And so one thing that I find very helpful when I have an adolescent in my office who's trying to convince me that their use pattern is social, that every single kid in their particular high school uses before and after school, is to look at national data and to get a better, kind of helps it's a reality check in a way. We have several national surveys that give us insight into how common substance use is, both in adolescents, emerging adults, and older adults. And this is looking at data from the National Survey of Drug Use and Health, which is a community-based survey done in 2015, and looking at the percentage of use of different substances over the past month. And you can see that you can see generally that that substance use peaks in these emerging adults. So that's the red bars, the 18 to 25-year-olds. The blue bars are the 12 to 17-year-olds. And then you see that generally substance use declines in people above the age of 26. So these emerging adults are definitely kids that we really need to be worried about. And then if you look across substances on the far left, it's any alcohol use over the past month, binge alcohol use, which is using a large amount of alcohol in a short amount of time. And then heavy alcohol use is frequent binge episodes over the past month, and then illicit drug use. And I think in Massachusetts, there's a lot of press about opiates and about marijuana, and there's less press about alcohol, but you can see that the binge alcohol use and heavy alcohol use are in large, overall kind of more common than illicit drug use. And when we look more specifically at adolescents ages 12 to 17 and their use patterns across substances over the past year, you again see that alcohol is the most commonly used substance in 12 to 17-year-olds. So it's definitely something that is frequently normalized. It's not being talked about as much right now, but is something that we really need to keep our eye on and to watch out for in kids. And then in terms of illicit drug use, cannabis is in the survey illicit, but in Massachusetts is a illicit substance. But I will point out that it's not legal for kids under the age of 21 to be using marijuana. So for these 12 to 17-year-olds, it still is an illicit substance. And then as you move across, you'll see that in terms of frequency, it's misuse of prescription stimulants, misuse of benzodiazepines, prescription opiates, heroin, and cocaine. And one thing to think about is that these kids don't use each of these substances in isolation. They're often combining them, and often combining them is where we really see increased risk in morbidity, mortality. And so I think we're all aware of the opiate epidemic and risks associated with misuse of opiates in terms of risk of overdose. But it's also important to recognize that you're very high risk to overdose with benzodiazepine use, and particularly if you combine benzodiazepines with alcohol. And so those are not substances to be treated lightly, even though often, in particular, as I've mentioned, alcohol use has been somewhat normalized, especially among adolescents.
Could you define illicit, please?
Illicit means just that it's not legal. So,
Why aren't heroin and cocaine there?
or there are,
That was
oops.
confusing.
Sorry. So these are all, in terms of its kind of illicit drug use, encompasses all of like cannabis, misuse of prescription stimulants.
So all those add up to that.
Are included within that. So, and in prescription stimulants, if you're prescribed them, you're using them legally. But if you misuse them, then that's illicit use. If that kind of helps. So, a question in the back. And that's just, it should be mentioned. I think one thing to kind of mention about tobacco or about nicotine is that overall we've seen declining rates of tobacco in adolescents. And when we look actually at daily use of tobacco versus daily use of marijuana, it's more common nowadays for kids to be using marijuana daily than it is for kids to be using tobacco daily. But as we've seen this decline in tobacco use, we've seen an increase recently in electronic cigarette use or vaping. Or you guys may have seen stuff in the news about Juuls, which is a particular type of electronic cigarette. But go ahead.
I was talking with somebody in his late, and he's a high school graduate. He actually had to quit high school. Out of high school. Shocking to see. I mean, there's a law, you can't smoke. And he has to quit high school.
Yeah, but I mean, I think it kind of does raise that nicotine can be a really big problem, and you know, I'm somewhat remiss in not having it on the slide, so I'll own that, and you know, we do see that that's often one of the first substances that kids use or misuse prior to going on to misusing alcohol or cannabis, and in electronic cigarettes were not regulated until just like 2 years ago, and so that's part of the reason we also saw higher rates in adolescents, and these increasing rates is in part related to access. So kids often misuse what they can access, and so you know, we can't control a lot of stuff about youth, but you know, in terms of thinking about access, we can think about kind of keeping prescription medications safe and locked up, and disposing of medications that we don't need anymore, and then think about how we store alcohol potentially in the house, or if someone has medical marijuana, how that's stored in the house. And so those are some things to think about. That kids they use what they can access. So maybe one quick question, then we'll get going.
On the benzos, just be aware that normal drug panel testing won't pick up a benzo unless you 14 or 16 panel drug test. So just be aware of that. It became a huge problem about 10 years ago, but across the rest of the United States. So it's interesting how certain cities have worse problems with certain drugs, and benzos are huge.
Yeah, but I think it also speaks to kind of if maybe you're thinking about doing toxicology testing with an adolescent that you're concerned about, to always know what you're testing for, because also standard toxicology screens don't always pick up synthetic opiates like prescription opiates or fentanyl or things like that. So it does highlight a point about toxicology screens. So in terms of, what are risk factors that increases in adolescents' risk to develop a substance use disorder and makes them more vulnerable? I think the developing brain has already been talked about. And just one kind of analogy that I will often share with parents is that, again, the control part of their brain hasn't fully developed and won't develop until the mid-20s. So kids are driving a car with a functional gas pedal but no brakes. And so that's kind of one way to kind of visually think about that when you're like, why did they do that again? So they don't have brakes. And so that puts them at risk to make unhealthy choices and be at greater risk for a substance use disorder. Early onset substance use definitely increases your risk of developing a substance use disorder. I mentioned access, so that's a really huge one for adolescents. We'll often hear these stories of, they started with e-cigarettes that they were more easily able to access, misusing cough syrup when they're 10 or 11, and then kind of escalates to what they're able to get in terms of through their peers. And so peer pressure, and if a child has peers that are frequently using substances, they're at much higher risk to use substances and potentially develop a substance use disorder. Academic difficulty, family conflict are also things that can increase risk, and then family history of a substance use disorder. And then I do want to highlight how just risk associated with having a psychiatric disorder. This is looking at your risk to develop a substance use disorder if you have one of these psychiatric disorders. And so these are odds ratios. And so if the odds is greater than 1, you're at increased risk to develop something. And so for example, if you have oppositional defiant disorder or conduct disorder, you're at nearly 5 times greater risk to develop a substance use disorder than kids who do not have oppositional defiant disorder or conduct disorder. And so I think it's really incumbent upon child psychiatrists, psychologists, and pediatricians to really keep a close eye on these kids and really kind of try to do what we can to promote their engagement in positive activities and positive pro-social activities to help, hopefully decrease their risk maybe for developing a substance use disorder. But these are kids at greater risk. What are some signs and symptoms of a substance use disorder? Potential behavioral changes that a parent might notice is that an adolescent might be more withdrawn, might start to have a decline in academic performance, decreased interest in sports or hobbies. And all those 3 things are fairly nonspecific, so that could mean many different things in an adolescent. But one other kind of big change that sometimes we see is a change in friend group. And so that's definitely something to keep an eye out for. And it's important that parents, ask kind of who are you hanging out with, kind of what are you doing, what are these kids like, that those things really make parents often feel sometimes hopeless in the face of peer pressure, but kind of knowing what your kids are doing and who they're doing it with can really make a difference. In terms of diagnosis, actually meeting the threshold for the diagnosis of a substance use disorder, there are 11 different criteria that we go through and assess for, and those include someone's having difficulty controlling their use, they're continuing to use despite consequences, so they've gotten in trouble at school, they're getting in trouble at home, and they continue to use. They're using in risky situations. They also develop tolerance, so they need to use more of a substance to have the same effect. And they also may have withdrawal symptoms. And I think people may be aware of that alcohol or opiates or benzodiazepines have a withdrawal syndrome. It's also important to be aware of that that marijuana has a withdrawal syndrome, and that can include if kids have been using marijuana frequently, when they stop their marijuana use, may have increased difficulty with sleep, increased anxiety, irritability. And so there's those symptoms of marijuana withdrawal, which for a long time people didn't think actually existed, but does exist. And then in terms of language, we've been talking about how that's important, and the kind of how we make the diagnosis of a substance use disorder did change a few years ago to using the terminology mild, moderate, or severe, and that's based on the number of criteria someone endorses for a substance use disorder. And we no longer use the terms substance abuse or dependence, and do think of those as somewhat pejorative terms. And so really, it's nice to have this different language that we can use. In terms of, we talked about prevalence of use, in terms of who actually meets criteria for a substance use disorder, about 11% of adolescents over the course of their childhood and adolescence have met criteria for an alcohol or a drug use disorder. In terms of who receives treatment for their substance use disorder, this is looking at different psychiatric diagnoses and the percentage of youth who have received services for that diagnosis. And so that you see that 60% of kids with the diagnosis of attention deficit hyperactivity disorder have received some sort of treatment for ADHD over the course of their lifetime. Whereas in contrast, only about 15% of kids with a substance use disorder have received substance use disorder treatment. So why don't adolescents receive treatment? One is that it's often difficult to find treatment. When you're concerned, it can be hard to find child psychiatrists or psychologists who are kind of trained and ready to work with kids and families around these issues. Often adolescents not willing to go to treatment. They don't think they have a problem. So if you don't think you have a problem with something, why would you go see a clinician about it? Substance use sometimes isn't perceived to be a problem. It's kind of been normalized within that kind of particular town or friend group or kind of culture. And then there's also still a lot of stigma associated with substance use. So it's much easier to go to a neighbor and say, hey, what dentist should we use? And it's a lot harder to sometimes go and say, like, I'm really worried about my child who's, struggling with marijuana or alcohol use. Do you know of someone that treats substance use disorders? So generally, when do people end up walking through our doors? How do the 15% of adolescents get to us? And generally, it's when they're having problems, and that can be their substance use is leading to psychiatric symptoms. So their cannabis use might be causing psychotic symptoms, or substance use causing depression, anxiety. It can more severe use disorders lead to physical problems like skin infections, liver infections. Legal problems are a common reason why people come into treatment, and so we like probation officers actually. So they're our friends because when kids are kind of legal and justice involved, they often are more likely to come because they're concerned about legal consequences if they don't come to treatment. And then school or kind of problems at school is another frequent reason for referral or presentation in our program. And then kids are often having problems at home prior to having problems at school or kind of with the court system or kind of developing a physical illness or psychiatric disorder. And so we would love to be seeing them when they're having problems at home. And sometimes, again, there's a little bit of avoidance because this is really kind of, you're not sure, is this a problem? Is this not a problem? The teenager definitely does not see it as a problem, and this is hard to talk about. But we know that earlier intervention is associated with better treatment outcomes and would love to be intervening earlier when it's first starting to be a problem. And so if there's ever any concern, I think it's, a good choice or good decision to check in with a pediatrician or check in with a clinician if there is some kind of concern that your child might be having substance use problems in the home setting. And so how do you get them to treatment? It's easier said than done. But I think really talking about your concern and being open and honest about that concern and asking them, I'm not saying that you have to necessarily stop, but I'm just asking that you go talk to somebody about it so that we can kind of get another viewpoint and get some support in kind of how we think about this. Or so you're not kind of asking your child to do everything in that one conversation. You're just asking them to go and talk with someone about it. And the goal is, again, is really to motivate your child to come for an evaluation or come for treatment. And so if that doesn't work, talking about the concern, sometimes parents need more support in terms of putting in more positive rewards for coming to treatment and clearer negative consequences if kids continue to use substances. And so we use a model called the Community Reinforcement and Family Training for caregivers that really helps teach these principles of contingency management, which is about kind of positive rewards and negative consequences, and then helps build communication and problem-solving skills, because these things, again, are really hard to talk about. And then this is also really stressful. Parents are often, terrified when, they have a concern that their child's using substances. And so one piece of this intervention is to also kind of help parents start to take care of themselves. And so what does the treatment look like when you do get them to treatment? It really takes a team. And who are kind of those members of the team? Treatment components include therapy, often medication, family involvement, and peer support. And And one thing just to make a point of is that there, one person can't do this all. So, often, sometimes for anxiety disorders or other disorders, somebody is able to do both medication management, therapy, and some parent guidance. With substance use disorders, you really do need to have at least 2 providers because I can't effectively give parent guidance about how the parents need to kind of take the car away or take the cell phone away if they continue to use marijuana when I'm trying to get the kid to open up and talk to me about what's going on. It just doesn't work. So it really takes a team. And the team that we have here at Mass General is the Addiction Recovery Management Service, and this is a program that was started about 11 years ago with a large gift from philanthropy. It's a multidisciplinary program, and we have psychologists, social workers, psychiatrists, a nurse practitioner. We see about 250 new evaluations of young people per year, and we work with young people under the age of 26. Although if we have an emerging adult who is undergoing sustained retreat at age 27 or 28, we're still happy to work with them. So. And one of the services that we often are starting with parent engagement because, again, many kids are not ready to talk about what's going on or don't view it as a problem. And so we have a free parent group that meets, there's 2 free parent groups per week, and then any parent is welcome to come. Their child does not need to be a patient in our program to come to the parent groups. And we also offer individual parent guidance that's billed through insurance. And again, parents can come to our program without their kid being involved in the program. When we finally do get the adolescent or young adult through the doors, we do a thorough evaluation of their substance use, their mental health, and then really assess their readiness to change as we think about what intervention might be most appropriate. And then treatment, again, can include therapy, both individual and group therapy, medication management, and then also peer support. So these are some resources for parents if you're looking for kind of places to kind of learn more about this. And then just want to highlight our phone number down there so that we're a local resource. Again, we have this free parent group. If you want to come to parent group on Thursday at 5:30, then call Chloe at that phone number and we'd be happy to see you. So thank you for your time.
Be up here.